Thank you, Tina. Yes, as Tina said, I was supposed to present this yesterday, but there was a problem with the flight, a strike in the air controllers in Porto, so I couldn't make it to come here. But I'm going to briefly present you this update on nationally aggregated data. What is the usefulness and use in the local improvement work in Portugal? It's a very simplistic way of looking at things, but I think that could lead into some way of thinking that probably together we can find some solutions for the problems that I here mention. The picture that I'm showing you is a little bit of the example that I think that in the current moment of data aggregation we can think is, this was the library that is built on the 18th century in the palace in Mafra. This is only 40 kilometers above Lisbon. And it was at that time one of the biggest libraries in Europe. It has approximately 40,000 books. It was one king, João V, that was very rich at the moment. He had a lot of gold from Brazil, and he invested a lot in arts and culture. But curiously, all that data was available for the noble ones, but they usually go to the palace only for hunting. So the data was available, but they didn't use the data as it was supposed to. And even 3 centuries afterwards, we still have that data. It's an immense set of books, but we think that probably it's not as used as we should. So it's just a small thought about this. My presentation will be divided into big 3 areas, and it's going to be quite simple because I'm going to focus a little bit about the retrieval of data at the current moment in Portugal, how the analysis is performed, and the impact of this data. The retrieval of data is quite simple at the moment because we have a disseminated use of electronic health records since 2006. And this electronic health records has some areas of general information about the patient and family, such, for example, the normal data. It has also an area of clinical coding for the ICPC2, for the reasons for encounter, for the health problem and plan for each encounter, and this is according to the WEEDS method. And also we have a health problems list that is being coded by the ICPC2, whether the current, whether the past problems. We also have an area with the measurements and lab results, everything that the doctor and the nurses, they measure, they usually place it in the system. And the lab results have to be manually introduced. So usually it takes a lot of time, but this is the way that data goes into the personal health records and the electronic health records. We have a module for electronic prescription of medication, but also for special treatments, for example, respiratory treatments to make at home, or rehabilitation for physical therapy. And we also have the vaccination plan, which is fully digitalized. And this is usually the organism that is responsible for managing and collecting all this data. It's the Central Administration of Health Systems, and they make this software, which is called MIM. It's available at each primary care unit to be used for the physicians. Usually there is one contact person at each unit, at each primary care unit, that has the codes to access the program. And you can see all the patient data, whether some of the patient data that is registered, the productivity of the doctors, the costs, and some quality indicators. But these quality indicators are usually defined by the ACSS. So it's a set of national indicators that are currently being assessed in every primary care unit. One of the problems we have is the access to the information has a one month delay. So usually only on the 20th day of each month you can access the previous data to the previous month, because it takes some time to analyze all the data, because they are not localized on central servers. They are on each primary care unit has its own server, and then it migrates the data to the central ones. The analysis is performed by reports. So when you go to the system and to the electronic software, you have reports that, for example, give the total number of registered patients, whether in the clinic, whether, for example, in each doctor. You can also see the results for the quality indicators that are contractualized with the local health administration according to some specific goals that are defined at a national level, but then adapt in the local level. You can see also the productivity, not only by GP, but also by the specific chronic care programs, such, for example, hypertensive or diabetic patients. You can see the data for the chronic diseases into the problems list. And you can also see the problems that are identified in each consultation, the prescribed and reimbursed medication, because some of the prescribed medication are not reimbursed because the patients don't actually go to the pharmacy to take it. And also there is a lot of data from nursing, mainly preventive and therapeutic activities, and also the vaccination, which is direct responsibility from the nurses. And there is some biometric data also. So this is about the quality indicators. That it probably is one of the problems we have currently, because these indicators are defined centrally and we don't have enough influence to try to make it more comprehensive for our point of view and the primary care specialist point of view. For example, we have this indicator that is the percentage of patients seen by their GP in the last year, and now the cutoff value is approximately 85%. And there is probably no evidence that supports this cut level. So, but we are being forced to sometimes you can imagine to call patients that usually don't come to the practice, but some GPs have to invite the patient to come to the practice for example, to make a simple health status assessment without a proper reason from the patient to do that. For example, you also have this is the one I was speaking was about this, the second one. The one is the continuity of care. So you have to be seen 85% of the cases by your own GP, because we are divided by the patient list system. You also have an indicator for accessibility for the home visits for 1,000 registered patients, with approximately 30 per doctor. And this is some effectiveness indicators, the percentage of women with a pap smear, the registered mammography in the last 2 years, the diabetic patients with 2 registered glycated hemoglobin in the last 12 months, and the percentage of hypertensive patients with 1 blood pressure measurement every 6 months. So it has to be 1 measurement in every semester. And imagine this is 95%. So it's quite difficult to actually reach this cutoff values. We also have some dimension which is regarding to patient satisfaction, and the other one is regarding to the cost of medication, that usually the administration forces or pressures the teams to diminish the costs. Medication approximately 1 to 2% each year, and the cost of the exams, the reduction of 10% probably each year. The problem is that this is going cumulatively, so it's not going to reach some lower level, but they are always trying to get it lower and lower, which is of course a little bit irrational. Well, regarding to the last aspect, the impact of data, and this is probably the most sensitive issue, is that it's good that we have this kind of national aggregation of data, because it quantifies some of the provided care. Approximately a lot of areas are not here assessed, but it's the dimension of accountability has increased regarding this way of accessing care. It promotes the continuity and excellence of care, because we do some PDSA cycles and we also improve quality, but we are very on our own. This is the not so good aspects, because normally it deranges comprehensiveness. Professionals are more focused on the data that matters and probably will lead to an indicator-based medicine. And mainly, sometimes without appropriate interpretation, data can be dangerous, whether it's not used only for internal improvement, but also used by external agencies that want to influence the work of professionals. And one of the biggest problems we feel in a daily basis is that we have no feedback to the National Health Administration. They are very inflexible to adjust this kind of values that they force the practices to achieve. And there is no coaching or no implemented coaching system for quality improvement on the practices. So this is just a small idea about the impact of data in quality improvement. It also, of course, it pushes quality improvement by helping to identify and analyze problems, and also pulls quality improvement by helping to identify and analyze opportunities. But sometimes we are always between data and information. It's very difficult to pass from information to knowledge. And this is a very important step, because only after knowledge we can then have decision and action that it can really matter and go into the outcomes. For example, this is the data that goes annually for each practice, and you have also the green, yellow, and red flashlight systems. And these are the national indicators. So this is delivered to the practices, and they don't actually, for example, have, sometimes it's very difficult to contest some specific results, even when they are very high. Imagine, for example, some 10 or 15 patients we had problem in making that surveillance, it can endanger 1%, and then the indicator goes in yellow or red. So it's quite difficult to convince the administration that some indicator was quite good, but only because of some certain amount of patients it wasn't fulfilled. But afterwards, we see that in the last 3 years, 3 to 4 years, the quality of care has been increased. This is, for example, the rate of medical appointments. It has increased a little bit. We are approximately in 68.8%. It's quite good in primary care. So it promotes primary care, has the first access. This is, for example, the home visits have increased also. The percentage of diabetic that have 3 glycated hemoglobins in the last 12 months, there was a little change in the indicator. Generally, it goes quite well. This is the hypertensive patients. It goes slowly because probably if they are controlled, they don't need so much regular measurements. And this is also the breast cancer screening and the pap smear. So sometimes we feel that we are always feeding the computer with data, and this is becoming a little bit disturbing for us doctors, that we are giving data to the National Health Administration, but the feedback and the coaching for the quality improvement is lacking a little bit. And we think that nowadays, and this was an article published some years ago about Simon de Lusignan and Chris Van Weel, the challenges for data and the research that we probably can achieve with data, this should be addressed in a very serious way. We should identify the appropriate research methods for analyzing data from primary care databases. Probably it's not just collecting information. There should be a specific methodology for it. How to infer meaning from that data. We are showing numbers, but we don't actually know what this kind of numbers say. The pace of change is very difficult also, not only from the point of view of the professionals, but also from the teams and also from the administration, because, for example, the implementation of electronic health record can change and can take a lot of years to make it more accurate and to actually measure what we need. And the need for integrating systems, I've seen during this day that there are 10 electronic health record systems in one country, the other has 12, the other has 17, so it can be quite difficult to make this into a single system that measures correctly. And a lot of ethical issues come also, the data ownership, the security, confidentiality, and privacy. So I think that we should also focus mainly on these issues instead of having more data. We should probably try to see if the data that we are having is actually accurate, it's correct, it's done in the good way, and it's replicable in different countries. One of the last position papers from the EQUIP was the measuring quality in healthcare, and some of the principles that it defended was all indicators that are used for benchmarking or external evaluation should be scientifically tested and validated, and they should be approved by the profession. And we see this probably it's not respected in many countries. At least in mine it's not, because we normally see the health administration forcing indicators that are probably not accepted by the profession. And also personal health data should be gathered only with the intention to quality improvement. Mainly, in some situations it's not. It's just to have some certain of inspection and to see if actually those doctors are behaving good. But probably behaving good is not actually achieving good health outcomes. And measuring quality without a planned way to analyze and use the results and with an intention to improve processes has very little effect on patient care and is therefore not recommended. So I think that we also have a lot of regarding this, because we are sometimes extracting data and we don't have a definite cycle to improve the quality. We just have the first part of the cycle and we don't know what to do with that data. One of the authors that I usually think about when I think about this idea of having information, knowledge, wisdom, etc. is T.S. Eliot, because he wrote some years ago that the endless cycle of idea in action, endless in invention, endless experiment brings knowledge of motion but not of stillness, knowledge of speech but not of silence, knowledge of words and ignorance of the word. Where is the life we have lost in living? Where is the wisdom we have lost in knowledge? And where is the knowledge we have lost in information? And I think these are very wise words, because probably we need to find out the knowledge and information and the wisdom and knowledge. So one of the recent articles from Tricia Greenhalgh in 2011 was this one published in the Milbank Quarterly that said why national e-health problems need dead philosophers. It was a Wittgensteinian reflection on policymakers' reluctance to learn from history. And one of the parts of the article says that critical academics have proposed that the introduction, implementation, and evaluation of e-health problems inevitably reflect and perpetuate the wider alignments of political power, which Michel Foucault called the regimens of truth. But it's arguably not necessary to view the world through a Foucauldian lens to accept that when policy making takes a rationalist turn, and this is what my main idea was, this shifting from deliberative to rule-based decision-making, focusing narrowly on the pursuit of what works, valuing managerialism over professionalism, and introducing an even tighter surveillance of performance, it becomes almost impossible to articulate a national, and I focus here, a national e-health problem, as anything other than a detailed advanced specification with firm milestones and carefully designed work packages. In such contexts, those working to implement policy have little choice but to view the key task as controlling, coordinating, and aligning these various packages rather than, for example, understanding and accommodating the various nuanced language games being played by different stakeholders. I think this is even more updated as the time goes by. And the conclusion was that the complexity of contemporary healthcare, combined with the multiple stakeholders in large technology initiatives, means that national e-health problems require considerably more thinking through than has sometimes occurred. And I think that we have seen, for example, a lot of good national e-health problems in today, but have they been thought enough, or have professionals, for example, been involved enough, or has patients being involved enough into this national e-health problems? We need fewer grand plans and more learning communities. And this is, I think, it's a really interesting challenge. And this is also an interesting conclusion, is the onus, therefore, is on academics to develop ways of drawing judiciously on the richness of case studies to inform and influence e-health policy, which necessarily occurs in a simplified decision environment. And I think, for example, the Finnish quality networks, which are very personalized and very focused on the needs of the teams, probably are one of the good case examples and could be a case study of how to implement a local and very specific quality improvement process. So, according to the main three areas that I actually thought about this subject, the retrieval, I think it should be a really big focus on the resources that we allocate to this, and also the time that is needed by professionals and the impact this has on the care, the direct care for patients. The analyze should be focused on the dimensions of the quantity, whether we need so much data or we need better data. But what is the better data? It's probably very focused to the context of the data, the local context of the practice, and the meaning of the data. It's also very difficult to say that more controlled glycated hemoglobin means more better care to patients. Probably will not lead, but it depends a lot of context and meaning. And the impact that it has, whether in professionals, because if I'm a more experienced GP that's not very used to this kind of to big brother eye in the way that I do, probably I will decrease my internal motivation for quality improvement. And this has a very serious impact. But we should also focus the improvement and help people to improve. What I think is probably one of my main messages is that we should retrieve proper data to produce information, but we should analyze the meaningful information to create knowledge. And we should adapt the knowledge to be more contextualized and translational in order to impact professionals towards wiser doctors. And I end with this image because I'm also a big fan of Caspar David Friedrich. He's one of the Romantic painters. And this image was also a little bit about the solitude and the indefinition about sometimes knowledge becomes. And I think that sometimes GPs are wanderers in the mountains and valleys of healthcare. Sometimes they are below, sometimes they are above. But the main issue is that sometimes the sea of fog masks the path and their goal, which is to take care of the patient. And I think we are in some certain era where there is a lot of sea of fog. That probably could be the overburden of information, the overburden of scientific advances, the overburden of technology, or maybe the overburden of data that probably will not lead to better information and to better knowledge and to wiser doctors. So probably we'll need to focus on very specific data that could create the wiser doctor in order to improve care. Thank you.